All right, so I always like to first start out the presentation, I will go into some different recommendations for products to use that might be helpful. I don't have any financial relationships, commercial interest or anything, so I just wanted to preface it, but I am going to give you guys some recommendations. So a few things to discuss today. I want to talk a bit about sexual response, the normal sexual response cycle in women, common causes of sexual problems in the general population versus the cancer population. There is some overlap, but obviously things are much more compounded when you bring cancer into the mix of all of this. There are many sexual side effects as a result of treatment. I'm going to talk about vaginal dryness and remedies to help with that. I'll talk about vaginal dilators, which are basically vaginal stretching devices that can be used, and then pelvic floor physical therapy, which is a very useful resource for us. Low libido, and then I'll talk about hot flashes and some treatments for that. And feel free to ask questions. I think they prefer you to wait towards the end, but I'll be available for that at the end of the program. So sexual response cycle. So we talk about it as there's 4 phases in the sexual response cycle. So first we talk about desire or libido and just having an interest in sex. After that, there comes arousal, or when you're excitement, and in females, this is clitoral engorgement, orgasm, which may or may not happen, and then resolution. So this is not always in this order, and I can't really stress this enough. So a lot of people talk about how they may not have desire or interest, but if they do engage in a sexual activity, it's not painful, and they're able to get aroused and have enjoyment, then that in turn can influence libido in a positive way. So sometimes I've heard some patients say that there's a desire for emotional closeness being a motivating factor versus sexual activity itself. So there can be everybody's different, and not everyone fits into the same mold with all of this. So this was a questionnaire, and this is not specific to ovarian cancer, but all the cancer patients that we saw in our program. And this was a questionnaire asking if people were sexually active, yes or no, and then if they were not sexually active, what was the reason for why? So 38% of people reported that they had a physical problem, making it difficult. So basically vaginal dryness or pain, making intimacy difficult for them. A quarter of patients said that they weren't interested in sex. Some did not have a partner. Some reported fatigue, which is really common. If you're fatigued, then libido obviously is going to be low also. And then partner issues. So partner could have sexual dysfunction problems as well. So this is a little bit of a wordy slide. I'm sorry about that, but I did want to list some of the common causes of sexual dysfunction. And that's just really the term that can kind of encompass any of these issues. So lack of desire, trouble with orgasm, or pain. So anything under that umbrella. And a lot of people that I talk to have a combination of these things going on. In the general population, there can be, or in women with cancer, there can be partner issues. So relationship factors or sexual dysfunction with a partner. So if you're not feeling close to your partner, if there's relationship struggles or something going on, then obviously you might not be as interested. Menopause, which in some people with ovarian cancer was existing prior to the cancer, and some people that the surgery put you into menopause. So that's a huge issue. Childbirth, fatigue, stress, anxiety, and depression. There's lots of health conditions outside of cancer that can affect sexual dysfunction. And then there's several medications. So the common medications that can affect sexual function are a lot of the antidepressants. Many of them are given in women with cancer that are dealing with anxiety, difficulty sleeping. A lot of times we give low doses of antidepressants for hot flashes. So it's kind of a balancing act. I mean, if you're taking an antidepressant and it's treating your depression and making or helping you sleep better, then obviously it might be a good thing sexual function wise, but then at the same time, it can make it lower libido and make it harder to have an orgasm. In the cancer population, there's obviously hormone deprivation, which can happen with chemotherapy, with surgery. Radiation I listed here, but that's not really a common treatment for ovarian cancer. And then medications can also impact, whether it's immune therapy. Some people get estrogen blocking drugs that can further impact high-grade serous ovarian cancer, which is the common one many of you may have. That's typically not treated with hormone blocking drugs, but some types of ovarian cancer can be. So that can also impact sexual function. Fatigue is a huge, huge player in the cancer population. Trouble sleeping, sometimes changes in body image, or if there were infertility issues as a result of your treatment. So common symptoms in menopause or after ovarian cancer treatment. So we always think about vaginal dryness. I think that's a common one that many of us hear about. Burning of the genitals, so itching, burning can be a symptom. Sometimes irritation, and a lot of urinary symptoms actually. So the term for vaginal dryness, the medical term used to be vaginal atrophy, and they actually changed this to genitourinary symptoms of menopause, because many people will have all these urinary symptoms and there's not actually an infection. You should of course go and get checked for an infection if you are having urinary frequency, burning, or pain, but sometimes it's actually no infection present and it's menopause and the absence of the hormones that is what's causing these symptoms. Recurrent urinary tract infections can be more common after menopause as a result of hormone deprivation. And one thing I really can't stress enough is avoiding scented soaps in the genital area, baby wipes, even if they're unscented, those can be really irritating. Obviously no douching, and then panty liners, if you have to wear them because you're having some leakage of urine or incontinence, then that's fine. Of course, if you're out and about, you need to wear a liner. But I would encourage you to put on some Aquaphor on your skin, because it actually works as like a barrier to protect the skin. When I've done exams on women that use panty liners all the time, their vulva, the outside of the vaginal area, is almost like a bright red color because of just the chronic panty liner use. And liner's job is to pull away moisture. So if you already are having diminished moisture, you don't want something to worsen or exacerbate that. So lots of different lubricants out there, and there's a lot of, most are fine to use, but some can actually be pretty irritating. So I listed some of my favorite brands that, can be helpful to use. Never use anything that's flavored or warming. Spermicides you don't want to use. And then I listed some of the common irritants. There's nothing wrong with some of these ingredients like glycerin, parabens, propylene glycol. Those things are not harmful for your health in small amounts, but they can cause irritation or burning. So if you're having trouble with the type of lubricant you're using, I would check the ingredients on it and see if maybe there's something better. I do usually have people start with a water-based lube. So the common ones we hear about are KY and Astroglide. And those ones do have some ingredients that can irritate. So I typically discourage people from using those. Good Clean Love, Aloe Cadabra are really good for sensitive skin. If you need something that lasts a little bit longer, so water-based lubes are going to dry out more quickly. Silicone lubricants and oils are going to last much longer. Coconut oil is a great one. I would suggest if you have recurrent UTIs or anything, you really want to be more careful with the oils because they can stick around on the skin longer. You should always, of course, urinate after any sexual activity, whether it's penetration or external. And lubricants really should be used even with external stimulation, even if it's masturbation. So always use a lubricant. And if you're with a partner, apply it to yourself and the partner. So the other piece, so many people, when they come to see us in our clinic, they're already using lubricants. Those are the common things we hear about. And I think anybody that starts to develop pain is going to go to lubricant first. Typically, though, you want something not just during sexual activity, but something on a regular basis. So these are examples of moisturizers that do not have any hormones in them. All of these are available without a prescription. The hyaluronic acid products are pretty helpful. Most of the patients I see really like Reverie because it's a suppository versus a gel or a cream. So it's not as messy. So you're going to insert this suppository vaginally at bedtime. The box tells you to do it twice a week, but I found 3 to 4 times a week is generally how much it takes. And you also want to use something on the outside. So around the clitoris, around the vaginal opening, you're going to want to put a moisturizer there. You can use these as much as you want. You're not going to overuse them, but usually 3 to 4 times is plenty. The one for external use that I like is Replens. You can buy this at any local pharmacy or online. Also moisturizing around the clitoris and the vaginal opening will help with insertional penetration pain and also can help with arousal response. So the clitoris is dry and the tissues are thin, then the arousal response or ability to orgasm is going to be a little bit more diminished. And on that note, I do want to just mention vibrators are actually a really useful tool. Like a handheld small external vibrator can help with arousal response too. So that's something that I would get if you feel comfortable or you don't have one already. And then I just wanted to include this picture just to show you where to put the moisturizer. So around the clitoris here, and then you also want to do on the smaller lips and then the vaginal opening, almost like go in with your finger when you massage in the moisturizer. The outside, like way out here where the hair is growing, you don't need any moisturizers or anything there. Though that skin is just like the skin on your hand or anywhere else. So it's more the fragile skin that you want to hydrate and use the moisturizers. So next I'm going to talk about some of the prescription treatments. Vaginal estrogen, we always start with something without hormones, but in most cases, depending on the type, but most types of ovarian cancer, it is safe and perfectly fine to use very low doses of vaginal estrogen. You should always discuss this with your medical oncologist, but almost always it's fine. The lowest dose is Imvexxy, and it comes in 4 and 10 micrograms. So prior to this, the lowest dose was 10. And when they looked at the study in the general population of menopausal women, the 4 microgram dose was the same as the placebo in terms of the blood levels of estrogen. So I know hormones can get a bad rep, but this is such a low dose that it's not absorbed in the bloodstream. It's really just local therapy in the vagina. So if you're really suffering and the non-hormonal stuff is not helping you, then I definitely would think about using the Imvexxy or Vagifem. These are just tablets inserted twice a week. There's also a vaginal ring that is placed. This has estrogen, and it's put inside the vagina, and it lasts for 90 days, and then it's changed. So it's just a different way. And then creams are sometimes used. So estrogen, these are the 2 different brands of vaginal estrogen creams. So I typically go with the tablets over the creams. They're lower dose and just not as messy. So people typically prefer using those over the creams. So some other drugs that you might have heard of for treatment of vaginal dryness or vaginal pain with sex after treatment. One is called Prasterone, which is it's vaginal DHEA, which is a hormone that our body makes. It converts into estrogen. So I have a lot of people say, well, isn't this better because it's not estrogen? But it actually converts to estrogen anyway. We have a lot more data on the use of vaginal estrogen than the DHEA, but this one probably is also safe. It is dosed every night rather than the twice a week. It did show a little bit of changes in systemic hormone levels in the bloodstream, but they still stayed in menopausal range. So they're not going to change drastically. The other thing that people sometimes ask about are topical testosterone. So this is like testosterone cream that's used at the vaginal opening. This is really, it's off-label use. It's not FDA approved. There's different dosages. Some are probably safer than others. It's not something that I've given just because we don't have a ton of data on it yet. And then some people use testosterone systemically, like, on their thigh or on their arm, and it's absorbed in their bloodstream for treatment of low libido. That is also something that, we don't have a lot of data on, and particularly the cancer population. It's not FDA approved, even in the general population. So it's something that I've stayed away from personally. There is an oral pill called esketamine. That is a drug that is taken by mouth, but it is for vaginal dryness. Some side effects are hot flushes and possible blood clots. So this isn't really anything, that's not a drug that I've given in our cancer population, but it is something that is out there if you hear about. And then the last thing on here that I wanted to mention, so lidocaine, it's usually given in an ointment or a gel. So I've had a lot of people have insertional pain with penetrative sex. So right at the vaginal opening, there was a study, it was actually done in a group of breast cancer patients where they looked at lidocaine versus a placebo, and it was very beneficial for people who had insertional pain after menopause. So that's one option. I do think it's more like a Band-Aid, it's not really treating the underlying cause. So if you're having a lot of dryness or there's tightness, there's other things we can do to treat that. But if we've tried moisturizers or dilators or other things, and you're still having this insertional burning or pain, then sometimes a little bit of lidocaine just before sex can be helpful too. And then the vaginal laser. So I always like to bring this up in presentations because a lot of people do ask about it. There's a couple different types of lasers. There's been some positive, there's studies that show that it can be beneficial for people that have vaginal dryness or thinning and pain, but it's not FDA approved for those indications yet. It's very expensive. It's not the first line treatment. First line treatment should be vaginal moisturizers or estrogen. And it basically what it does is it burns the first layer of tissue, so it regenerates new tissue growth and new blood vessels. So I've had some people do this outside of our institution. We do not do it at MSK. But it's not covered by insurance. It can be very expensive. And I just caution people that, they're not getting talked into doing this just because it's a cash business. And so you have to be careful that you trust the provider that you're going to. There have been some reports of burns and scarring after the laser treatment. So I would just be cautious if you're thinking about pursuing that. Make sure that you're talking to somebody about the data that you trust. So next, I'm going to move on to vaginal dilators. So these are super helpful for anyone that's having any sort of penetrative intercourse, or if you're having pain with vaginal exams. Oftentimes after surgery or after treatment, especially if it's been a long period of time that you haven't had intercourse and you're in menopause, the vaginal muscles themselves can get tighter and more narrow. And then also you're dealing with the thinning and the dryness of the superficial layer of tissue. So these dilators are kind of a gradual way to get back into intercourse. And you can use a size that's much smaller than your partner or a toy. And then you gradually work up in size. So the kits that we give out, they're 5 different sizes. The first one's the size of your finger, and then they go up from there. I tell people to use these about 3 times a week for 5 to 10 minutes, kind of rotating in circles as you go, and then starting at the opening, and then you want to go all the way to the very back of the vagina and kind of rotate there. After hysterectomy, there's a stitch in the back of the vagina. And so that area, sometimes people can have some tenderness there for a while. So using the dilator to kind of gradually rotate in that spot, once you're cleared to have intercourse, can be helpful. You can just gradually go up in size. If you use these once a month or once a week, they're probably not going to be helpful. But if you do them consistently, you should notice being able to move forward in size. The other great thing about these is they're not only physically helping with the muscle and making it more elastic, but they're also helping to kind of alleviate the anxieties and the fears around pain, because you've already tested it out and okay, I did this certain size and it's not painful. And so people tend to go into intercourse more comfortable and more confident, and not kind of bearing down. So like a normal response to pain is to kind of clench. And then when we do that, the vagina actually gets more narrow, and then it can kind of facilitate this pain cycle. There's a couple different websites. Intimate Rose, I would say, is a site that a lot of patients I've seen really like, and they have dilators. You can also get Soul Source, Buvatech. These are just different companies that make them. So pelvic floor dysfunction or pelvic floor issues are very common in really all of us. They are more common after menopause. They're more common after any kind of pelvic surgery. And the picture here, I wish it was like a 3D photo, but just kind of showing how many muscles are in this part of our body. There's so many. There can be two issues. So some people have really tight pelvic floor muscles where many of us has probably heard of Kegels, where, you know, if you're asked to do a Kegel, and when I examine patients, I'll actually have them squeeze around my finger. And if they're not able to fully squeeze, then I know that there's some dysfunction in those muscles. So that's usually my cue to kind of send to physical therapy to do further evaluation. Many people have pelvic pain, trouble with going to the bathroom, usually constipation issues, sometimes incontinence of urine. So if you're leaking urine when you cough or sneeze, you have the urge to go to the bathroom. Part of that could be pelvic floor muscle problem. Less commonly, a lot of people worry about things being looser or weaker, which we call pelvic floor laxity. That's actually less common in our clinic because usually with sexual pain, you're actually seeing like tight pelvic floor muscles rather than the laxity of the pelvic floor. So in PT, it's very, you know, some people are hesitant to go because it's a little bit intimate when you're seeing somebody that's, you know, manually doing an exam and kind of massaging these muscle groups. They do actually go in through the vagina or the rectum oftentimes to reach some of these muscles. But I can say that most people that are referred are so happy that they went and that, you know, it's really, really helpful to them. They also will work with you on different exercises. They'll work with you on dilators. And then I put in the website. You can actually look at through this website and type in your zip code and it'll tell you certified pelvic PTs in your area. A lot of times it does require a referral. But if you're having some of these side effects, I think it's worth asking your provider about a referral to pelvic PT or if they think that's appropriate for you based on your exam. So the other thing for pelvic floor that we sometimes give, there's not tons of data on this, but there is a little bit. Vaginal Valium is a muscle relaxant, and sometimes it's given when people have really tight pelvic floor muscles that aren't getting better with PT or with dilators. Then sometimes that vaginal Valium will help relax the muscle so that that pain is more minimized. So that can be super helpful. Okay, so low libido, this is such a common one. So I do want to talk a bit about libido. So one thing, I guess the biggest things with libido that I always like to ask people is, you know, how is your relationship going? Are you sleeping at night? Are you having hot flashes? Like, how are you feeling mentally? You know, all of those things can affect the fatigue, just not feeling like yourself. If you're in the middle of treatment, many times the libido can get better after treatment once you start feeling better and good again. There are very few medications for women, unfortunately, for libido, but there is one. Bupropion is actually an antidepressant, but it helps to kind of boost energy. So there's some data on people that have cancer fatigue and low libido that this might actually help. The couple of caveats with bupropion is that it can make it harder to sleep at night because it does kind of boost energy a little bit. If you're prone to anxiety, it might not be the best drug for you, but it is definitely given for people who I'm talking about a non-depressed group of people, just to help with libido and with arousal response. People who are taking SSRI drugs, which are antidepressant medications that can actually do the opposite and impacts libido, like I talked about earlier. Sometimes this drug is added to those to kind of counteract that side effect. So that's something that you can, if you are under the care of a psychiatrist, or even if your medical oncologist is giving you something, then I would talk to them about possibly adding this. Testosterone, I sort of touched on earlier when I was talking about using it vaginally. There's not long-term data in the cancer population, so I would avoid like systemic testosterone treatment for low libido. It is helpful, it does work. Unfortunately, when the ovaries are removed, women stop making a majority of testosterone, because even if you're in menopause, the ovaries continue to make some testosterone, which, the thought is that is a player in our libido. So even once your ovarian function has stopped, if they're still present, they will continue to make low levels of testosterone. So that's one theory about libido issues. Vyleesi, I listed this here. It's a newer approved drug. It's an injection that's given 45 minutes prior to sex. Most people I've talked to about this do not have an interest in using it, but it did show some benefit. It's centrally acting at the brain. It acts on certain receptors in the brain, and that's how it achieves its effect. But it's not a drug that you have to take daily. It's just prior to intercourse. Again, though, there's not data in the cancer population. These are just things that it's an FDA-approved drug for the general population. Some non-medicine treatments. So exercise really is great for cancer fatigue. It really helps to lift mood. It helps with sleep. It helps with anxiety, so many things. So just being more active can really help address also libido problems too. If you're feeling better and you have more energy, making sure you're getting enough sleep at night. And if there's something that's affecting your sleep, addressing that with a therapist or psychiatrist. Mindfulness strategies, couples counseling, and sex therapy can also be really helpful for libido problems. And then the one thing I always like to encourage people to do is, if you're having trouble with libido or even arousal or orgasm, is getting an external vibrator or trying to stimulate on your own after treatment, just to see how things work and see if you can get a positive response. Nothing penetration wise, just external clitoral stimulation. And sometimes if you get that positive response and things feel okay, then it can kind of wake up this part of you again. And then you can feel like you do want to be intimate. And in turn, that can impact your libido. So open communication with partners, and then some of the other stuff that we talked about here too can help. So I'm kind of on a topic a little bit different than sexual health. I do want to talk a bit about hot flashes. There are some non-medication treatments for hot flashes. Acupuncture probably has the most data. There are certain cognitive behavioral therapies. I've seen in studies hypnosis. I've never actually seen somebody do hypnosis for hot flashes, but there have been some studies and trials that have said that is helpful. Paced respiration is just a very simple strategy. So what that is basically, if you feel a hot flash coming on, it's taking a slow, deep breath in over 5 to 6 seconds, and then letting it out over 5 to 6 seconds. And by slowing your breathing, you're slowing your heart rate, and that should help kind of dissipate the hot flash. A lot of the kind of the instinct is, when the hot flash comes on, is to kind of hyperventilate, and then your heart rate goes up, you get more hot, and so this is sort of to try to reverse that so it doesn't get worse. The obvious things are, sleeping with layers at night, a fan, all of that stuff. There is a supplement called Relazin. It's very safe. It's made from bee pollen. It was studied in trials in Europe. It can be purchased online without a prescription. That can be helpful. It takes about 2 months to know if it's going to work. If at 2 months it's not helping, then you might as well stop taking it, because it's probably not going to be helpful. Antidepressants, so some are helpful for hot flashes, some are not. If you are on Zoloft or Prozac, you may want to talk to your doctor about switching to something like Lexapro, Celexa, or Paxil, because those are very similar drugs, but they are helpful for hot flashes as well. So Effexor is another drug, antidepressant, that's given for hot flashes. It's very effective. I would say it's more commonly used in some of the others in the cancer population. The one thing that is tough about that one is you can have some nausea and upset stomach when you come off of it or go on it. So you really have to be careful going on it really slowly, coming off of it slowly, which can be a barrier for that. Gabapentin is a drug that's given for neuropathy. It does make you sleepy. So it takes generally high doses to work for hot flashes. But if you're somebody who's getting hot flashes just at night, then taking a drug like gabapentin right before you go to bed might actually make you sleepy and then also help reduce the hot flashes, so you're not waking up all night. Oxybutynin is, this is an off-label use of the drug. So this oxybutynin is actually given for people who have urinary leakage or incontinence, but it has been shown to be effective for hot flashes as well. The side effects can be constipation and dry mouth. So those two reasons are sometimes reasons why people, aren't able to take that. But those are all the sort of non-hormonal treatments. Hormone replacement therapy. So a little bit controversial, but depending on the type of ovarian cancer, I have seen it given, and we do have some data that shows that it can be safe depending on the type of cancer that you had and your age. So this is, it's not completely off the table, depending on the type of cancer that has happened. So that's something that's given orally or as a patch on the skin to help with hot flashes, but we typically would go with the non-hormone route first. But depending on your specific circumstance, you might be a candidate to take hormone replacement, depending on age and diagnosis. And then on this slide, I wanted to include some different resources. Share is on here. And then there's the American Association of Sexuality Educators, Counselors, and Therapists. It's a place where you can find a sex therapist. I really like this Woman Lab. There's a lot of great articles. This is a female doctor in Chicago who started an organization for female cancer patients. So that's another great place to go.